So Dr. Peeyush Varshney is a former fellow from SCPGI Lucknow. He's currently assistant professor of GI surgery and liver transplant at All India Institute of Medical Sciences in Jaipur.
My slides are visible, sir?
Yes, yes. Slides are visible, Piyush. You can start.
My talk is the last talk, so I'll try to finish it in time so that we have time for discussion. So, briefly, just to give an idea what I'll be talking, a brief introduction of one slide, and then what are the different forms of abdominal tuberculosis and when is the surgery required in each form, and what are the more common types of surgery which are being performed for abdominal tuberculosis. So, extrapulmonary tuberculosis is around 40 to 50% of all cases of tuberculosis, and abdominal TB is the fourth most common variant of extrapulmonary tuberculosis. 1/3 of the patient at presentation or at the time of diagnosis have a disseminated disease, and surgery is indicated only for 15% of cases which are having complications like in the form of perforation, obstruction, bleeding, etc. So 20 to 40% of patients require emergency surgery, and we'll discuss how. So there are various forms of tuberculosis like lymph node, peritoneal, gastrointestinal, visceral, solid organ, and commonly these forms overlap. It's very rare to see a isolated tuberculosis of one particular organ in abdomen and the other is not involved. So these are mainly overlapping form. So to broadly, these can be divided into a diagnostic indication for surgery, then a therapeutic. Therapeutic may be elective or emergency. And finally, the histological surprise that we already discussed mainly in the solid organ TB when there is difficulty in making a preoperative diagnosis. And rightly said that surgery in abdominal TB depends upon the indication as well as the form of tuberculosis. So first is the tubercular lymphadenopathy. It is the most common manifestation, and more commonly the mesenteric, omental, and portal HDL lymph nodes and celiac lymph nodes are involved. And they may mimic malignancy as already discussed and can be an isolated manifestation, but it's rare. So where comes the role of surgery? Most of these lymph nodes can be diagnosed on CCT on the basis of characteristic CT findings and may be targeted on image guided sampling by the use of ultrasound guidance, CT guidance, or nowadays on the basis of US guidance. But there are certain cases which may not be targeted or the sample is inadequate and there is a high suspicion of tuberculosis which may need to perform a surgery for a lymph node sampling. So surgery is limited to those cases which are difficult to sample by non-invasive methods and or rarely in case where there is a nodal rupture with secondary infection and peritonitis. So this example like these cases, lymph node to tubercular lymph nodes are difficult to target and sometimes may require a surgery for sampling these. Second is the peritoneal tuberculosis. This is the most commonly following the reactivation of a latent tubercular foci in the peritoneum established via hematogenous spread mainly from the lungs and less commonly from the transmural spread from the infected small intestine. And visceral and parietal peritoneum both may be involved with tubercles and it may lead to exudative ascites and it may be found in 10 to 25% of the cases. So it has been divided into wet ascitic type, fixed fibrotic type, and dry plastic type. I'll not go into details that has already been discussed in the previous lectures. So where comes the role of surgery? In ultrasound guidance or CT guidance, the setting of demonstrable ascites, lymph nodes, or thickening of mesentery, omentum, these can be targeted. Ascites can be sampled and can be looked for straw colored ascites with leukocyte count of 150 to 4,000 cells per cubic millimeter and with relative lymphocytic pleocytosis and typically have a low SAG value of less than 1.1. If the ascitic fluid is non-diagnostic and the clinical suspicion of peritoneal tuberculosis is high, then a peritoneal biopsy is usually indicated in the form of a diagnostic laparoscopy. Blind biopsy usually have a low success rate. So in a systemic review, including 402 patients, the sensitivity and specificity was 93% and 98% in making the diagnosis of peritoneal tuberculosis. So at the time of laparoscopy, the findings may be thickened peritoneum with yellow to white lesions with or without adhesions, and fibroadhesive patterns. This is one of the most common pictures which may see at the time of putting a scope in the form of diagnostic laparoscopy. Other findings may be a violin string, fibrous strand, or omental thickening, and surgery is used also indicated in subset of patients of peritoneal TB presenting with acute abdomen due to tubercular peritonitis. In that case, only lavage is done, and biopsy needs to be performed with peritoneal tolerating, and the abdomen is closed usually without a drain, because the ascites will keep on forming and it will keep on coming from the drain. So usually drain is not placed, or if drain is placed, a very thin board drain is placed till the wound is healed, and then it can be removed once the wound is healed. Solid organ TB already discussed. I will just skip the slides. Next is the esophageal TB and the luminal TB, basically the esophageal and the gastric or gastroduodenal TB. These occurs rarely and they spread from the adjacent tissues and usually involve the middle 1/3 of the tuberculosis. In the stomach and duodenum, it is also a rare site of involvement, and it is also secondary to the pulmonary tuberculosis, and it may lead to the symptoms of gastric obstruction and obstructive jaundice. Then comes the luminal part, the TB of small and large intestine. It is the most common form, and it has been divided into 4 types, mainly ulcerative, hypertrophic, ulcero-hypertrophic, and fibrous. So this will have an effect of surgery, that what kind of surgery is needed. And lastly, the rectal or anal TB may present in the form of multiple fistulae, which may require surgery for the treatment. So now coming on to the surgical treatment, what are the most commonly performed surgeries and what are the indications? So first is for the symptomatic abdominal tuberculosis, the emergency indications like obstruction, perforation, and bleeding, in which we have no other options but to go in and do an emergency laparotomy. Second is the persistent symptoms for ileocecal mass, or there may be some partial stricture or in the form of cocoon abdomen. And finally, in the fistulizing intestinal tuberculosis. And diagnostic dilemmas like for diagnosing the peritoneal tuberculosis, or where we have a confusion of diagnosis between the Crohn's disease and tuberculosis, in which we need to resect the bowel. So there are 3 types of mainly bowel surgeries which are being advocated. First is the bypass. So in the bypass, whenever there are dense adhesions and we are not able to resect that segment, then a bypass may be performed between the 2 segments which are freely available, bypassing the strictures or the involved segment. But the complications are that it may be complicated by a blind lobe syndrome or a fistula formation, and there may be a recurrent disease in the remaining segments. So it is not routinely performed, just performed as a bailout procedure. Second is the radical or segmental resection. So mostly the segmental resection is performed. It is to eradicate the disease completely, and it is feasible with the advent of effective ATT. But it is hindered by the malnourished state. Usually the candidates are poor surgical candidates, and lesions also can be widely placed. So radical resection may not be possible in all the cases. And they have fear of post-operative complications in the form of an osmotic leak, enterocutaneous fistula, peritonitis, sepsis, and obstruction and wound infection. So there may be chances of reoperation for recurrent obstruction also. Third is the most common type of surgery which is being performed in the form of conservative surgery. The conservative surgery is the stricturoplasty, strictures causing more than 50% of the luminal compromise, and limited resection of the involved segment with primary anastomosis is usually done. And this is the most common type of surgery which is being advocated nowadays. So for non-resolving intestinal obstruction, which is refractory to medical and endoscopic treatment, surgery is usually required for obstruction. And obstruction is the most common complication, mostly by the stricture in 50% of the abdominal tuberculosis. 1/4 strictures may heal with the medical therapy, but 1/5 will require surgery, and 1/3 of these are long strictures and less likely to respond to medical therapy. And another indication is that when there is healing and fibrosis, these strictures may exacerbate and also may lead to obstruction and will require surgery. So the surgeries are stricturoplasty and segmental resections. Stricturoplasty is safe and abnormal for both small and large bowel strictures. It preserves the gut length, and for isolated tubercular stricture with no associated mass-forming lesions or perforation. Resection is preferred during emergency surgeries or absence of definitive diagnosis like in Crohn's disease, or it is associated with perforation. So, considering what primary anastomosis versus stoma formation, it depends upon the general condition and other parameters and the experience of the surgeon. This is one of the pictures showing the most commonly performed surgical procedure. This is the strictureplasty. The stricture is opened longitudinally and then closed transversely to make a wider lumen. And multiple strictures close to each other can often be resected. But if there is one dominant stricture, the strictureplasty is a good option. So, for perforation, obviously the surgery needs to be performed. The incidence is around 1 to 11%, and mechanism is due to obstruction. There may be a proximal blowout, or ulcer may eventually perforate due to the vasculitis, or there may be multiple perforations, and where the strictures are common. So, in this, usually patients present with peritonitis and sepsis. The outcome is poor with high mortality, and there is a significant diagnostic dilemma tailoring the surgical approach, that how to approach this perforation and what surgery to be performed. So already covered, like for emergency on acute abdominal perforation, the emergency laparotomy is required in 20 to 40% of the cases. And if there is a contained perforation like abscess, fistula, or massive bleeding, and in the form of ruptured nodal peritonitis, laparotomy and toileting may be required. So, free perforation, usually lavage and resection is performed, or if the perforation is small, a primary closure can be done limited, but it has a limited role in patients with poor general conditions or with multiple perforations. And if contained perforation within adhesions or a cocoon abdomen, then abdomen is explored very carefully for recurrent SIU, and careful adductolysis is done. And if any dominant stricture is found, then resection and multiple drains are placed. And in case of serosal tears or enterotomy, multiple drains should be placed, and all these enterotomy should be lateralized. And there should be aggressive post-op care, and antitubercular treatment should be started as soon as possible. And nutrition supplementation may be required in these kind of cases. For bleeding, although it is rare in tuberculosis, but bleeding may be there, and massive bleeding usually requires emergency surgeries. When the localization is not possible prior to laparotomy, then the site of tubercular bleed may be identified on the morphological changes, such as a stricture or a adjacent lymphadenopathy, or intraop endoscopy may be used for the localization. And after localization, segmental resection is usually preferred. For the ileocecal mass, the patients which are not responding to the tubercular treatment, or there is a form of obstruction, 10% might require surgery. And as already discussed, conservative surgery in the form of ileocecal resection is usually performed over more radical right hemicolectomy. And usually nowadays, a minimally invasive approach in the form of laparoscopy is also feasible, but literature has shown a longer operative time, but similar post-operative outcomes. Another is the cocoon surgery. This is the most common or the most difficult situation encountered by the surgeon. And the principle of surgery mainly are complete excision of the membrane by the sharp dissection, avoiding the use of a diathermy or energy sources, because may lead to enterotomies or fistulae later on, and minimal manipulation of the bowel, and beginning the dissection from the inner side of the mesentery, then going to the interbowel during adductolysis. And if there is a perforation during adductolysis, better to resect it. And if there is a proximal enterostomy, then the primary goal is to overcome obstruction and avoid further iatrogenic injuries. And it has significant morbidity in the form of postoperative endocrine fistula, obstruction, burst abdomen, and mortality to the range of 13%. This is one of the intraoperative pictures showing a tubercular cocoon, and surgical principles as already described. In cases of peritoneal involvement, when they're not able to diagnose tuberculosis preoperatively, and we have a differential diagnosis of carcinomatosis, diagnostic laparoscopy may be required. And the visual characterization of the peritoneal disease can accurately predict in these cases, but usually the challenges are putting a first port. So either doing an open method or use thorough study of a preoperative imaging in the form of CT or MR to choosing a right port of entry is usually helpful. And there is a limited expansion of abdominal cavity in the form of in where there is a peritoneal involvement, and the primary goal should be that we should have an adequate tissue for analysis, and energy sources should be avoided because of the cartridge artifacts, or the histopathologist may not be able to sample these samples later on. So sharp scissors or instruments should be used, avoiding the energy sources. And of course, when there is doubt of diagnosis, dissection can be performed and subjected to histopathology. A word about incidentally detected abdominal tuberculosis. It has already been discussed that if there is tuberculosis on a postoperative specimen, antitubercular therapy should be started. And if it has been incidentally detected during intraoperatively, then frozen section should be performed to rule out carcinomatosis. And if the proposed surgery should be proceeded if there is no carcinomatosis, and or there is a doubt of chronic inflammation or tuberculosis, and a post-operative antibiotic therapy should be administered in these cases. Just a brief review of two case series from India highlighting what surgeries are being performed. This is one of the series from Central India, in which they have described 50 cases, in which almost 36% cases were emergency. And as we can see that the most common region was intestinal, followed by small bowel and ileocecal region. And most common finding was stricture, and most common surgical procedure was performed limited resection with end-to-end anastomosis, followed by dialysis, and then more radical resection from right hemicolectomy, laparoscopy, stricturoplasty, and stomach closure. This is also one of the other study of more than 100 patients from probably Gujarat, and they have shown that most common surgery performed is limited resection of around 33%, and the most common intraoperative finding was strictures and ileocecal hyperplastic tuberculosis when the surgery is performed for intestinal tuberculosis. A word about endoscopic treatment, because nowadays endoscopic facilities are available at the centers of expertise. It should also be used whenever there is isolated stricture. It is a good alternative to surgery for readily accessible short and fibrous tubercular ileus strictures. The balloon dilatation is a safe option, but the experience is very limited, and the technique is safe and may obviate the need for surgery in these settings. To summarize, surgery is warranted for patients with complications such as perforation, abscess, fistula, bleeding, and high-grade obstructions. Patient with biliary obstruction due to stricture may rarely require biliary reconstruction. Intestinal obstruction is the most common complication, and patients with multiple or long strictures are less likely to respond to ATT. And obstructions may be exacerbated by ATT due to healing by cicatrization and fibrosis, and which may eventually require surgery. And surgical resection should be as conservative as possible, because there are high chances that patient might need a resurgery or reoperation later on. And multiple structures may be unable to stricturoplasty to avoid major resections. Bypass should be the last options when not able to resect, and alternative approaches should be utilized like balloon dilatation if feasible and available. Thank you.
So thank you, Peeyush.